I am Dr. Sapkal here. The title for discussion today is Clinical Pelvimetry or Pelvic Assessment. Clinical pelvimetry includes assessment of the pelvis at 3 levels: inlet, mid-plane and outlet. This one is the outlet, anatomical outlet I am talking of. So, this bony pelvis is assessed clinically or by per vaginal examination. So, it is assessed at 3 levels: inlet, mid-plane and outlet. Okay. When to assess the pelvis? Yes, it is assessed at term 15 days before expected date of delivery. Why so? Because in primigravida, the head enters into the pelvic cavity 15 days before expected date of delivery in primigravida. That is known as engagement of the head. But however, in multigravida, it enters the pelvis with onset of labor pains and uterine contractions. So, due to uterine contractions, the pelvis, the fetus enters, the fetal skull and the head or fetal head enters into the pelvic cavity. That is why pelvic assessment is done in primigravida 15 days before expected date of delivery, and multigravida, as she has delivered in the past. So, head is the best pelvimeter. Head has already crossed the pelvis previously with the childbirth. That is why pelvic assessment is required only with the onset of labor. How to assess the pelvis? What is the exact methodology? Verbal consent is, of course, is very important. Privacy is maintained. Female nurse should be standby. Aseptic precautions are required because we are doing internal examination. Bladder should be empty. If the bladder is full, the head, the station of the head and sacral promontory we cannot make out properly. So, make sure the bladder is empty. The position of the patient should be dorsal, comfortable position with the flexion of the legs. Gloved 2 fingers are introduced vaginally, gloved fingers are introduced, and we note certain points, that is known as assessment. So, what level we assess? We assess the soft tissues first and then pelvis, proper pelvis. First note the tone of the pelvic floor to exclude the rigid perineum, because if the perineum is rigid, there will be problem in the extension of the head during childbirth. So, first we assess the pelvic floor manually with the 2 fingers, we assess it. Next we assess the sacral bone. So, this is the sacrum. First we put 2 fingers like this and straightway the sacral bone we assess. First 3 sacral vertebrae are only felt clinically on examination. So, gently assess the sacral hollow, it should be well curved, and assess the side walls should be parallel. Next we assess the diagonal conjugate. We have learned in the past the diagonal conjugate is assessed by PV examination. So, we introduce 2 fingers vaginally, the patient is lying like this, we put our fingers, the tip of the middle finger should reach the sacral promontory, and this lower mark of the pubic symphysis is made out, and that is how we measure this distance from tip of the middle finger to this mark. So, that is what is diagonal conjugate. So, it is assessed clinically. Obstetric conjugate means what is the space available for the fetal head, posterior surface of the pubic symphysis and inner surface of the sacral promontory. This space is assessed, or obstetric conjugate is assessed by subtracting 1.5 centimeter from the diagonal conjugate. So, we know diagonal conjugate is 12 centimeters. This is 1 finger and this is second finger, 1 upon 2 is 12. 12 centimeter is the diagonal conjugate. Okay. So, this is normally the diagonal sacral promontory is not reached clinically. I cannot feel the sacral promontory. So, how can I assess the diagonal conjugate? No. If sacral promontory is not reached, means pelvis is adequate, it is roomy. So, we make a negative statement on the case file that sacral promontory is not reached. It is understood inlet is adequate. Okay. If sacral promontory is reached with difficulty, then only I will measure the diagonal conjugate. So, it is the distance between the sacral promontory and inferior margin of the pubic symphysis. If this distance is 11 centimeter, then it is borderline inlet contraction and their treatment is trial of labor. But if this distance is less than 11 centimeters, then it is a major degree of pelvic contraction, inadequate pelvis, and the treatment is planned cesarean section or elective cesarean section. We have learned obstetric conjugate is calculated by subtracting 1.5 centimeter from diagonal conjugate. Okay. So, this is how our plan of treatment depends upon the measurement of diagonal conjugate. Remember, if the diagonal conjugate is 11 centimeter, it is borderline pelvic inlet contraction and the treatment is trial of labor. If it is less than 11 centimeter, major degree of pelvic contraction, inlet contraction, and the treatment is elective cesarean section, not the emergency. Okay. Sacrosciatic notches. Now, I will feel for sacrosciatic notches when I am doing PV examination. Here they are admitting 2. This is a greater sciatic notch. Here I will put my 2 fingers on PV examination, and if this notch admits 2 finger means sacrosciatic notches, this side of the pelvis is adequate. Ischial spines next we feel for, if they are prominent means mid plane contraction is there, mid pelvic contraction is there, but they should not be prominent in normal pelvis. In male type of pelvis or android pelvis, ischial spines are prominent. In female pelvis, they are not prominent. So, I will write down a statement on the case record that ischial spines are not prominent. Then posterior surface of the pubic symphysis also, it should be smooth, round and curved, so that it should not obstruct the birth passage, and sacro-mobility of this sacrococcygeal joint is also predicted. It should be adequately mobile because this coccyx goes posteriorly during extension of the head. Next is I assess the pelvic outlet. Outlet is bounded by inferior rim of the pubic bone, and these are the 2 ischial tuberosities, and there is sacrotuberous and sacrospinous ligament posteriorly. So, it is a diamond shaped area. How do I assess this outlet, pelvic outlet or bony pelvic outlet? I assess with my abducted fingers. If abducted thumb and index finger goes here, means it is adequate. If it adjusts, there is less space and it adjusts abducted middle finger and index finger, then it is inadequate. So, this angle is inadequate. This is one way to method. Now, second way to to measure the subpubic angle is by putting 4 fingers like this. This is how subpubic angle wide. If it admits 3 fingers, I will say subpubic angle is narrow. Other way to assess is I put my 2 thumbs here. So, if it is narrow, they will be like this, the detection will be like this. If it is wide, it will be like this. So, these are few methods to assess the subpubic angle. Normal method, usual method is this one, inadequate, adequate is okay, this one. So, this is how I assess the subpubic angle. What statement I will make on paper? I will write down subpubic angle is wide. Now, next is transverse diameter of outlet. I mean, remove my hand, the patient is lying down like this, I put my 4 knuckles over the buttocks below the pubic rami like this. If it is admitting 4 knuckles like this, finally I will write down my all documents on paper, what are they. First I will write down sacral promontory is not reached, means inlet is adequate. Sacrum is well curved, means there is lot of space at the greatest pelvic dimension. Sacrosciatic notches admit 2 finger, side walls are parallel. Mid pelvis, there are ischial spines are not prominent, subpubic angle is wide and transverse diameter of outlet is admitting 4 knuckles. So, in one sentence we may write down pelvis is adequate on internal assessment or pelvic examination. Simultaneously, while I am doing pelvic assessment, I will assess the cervix also. The Bishop score of the cervix means it should be more than 6. There are certain points, we will learn them later on. So, it should be at least 8 to 10. 10 is very good score. Then the station of the presenting part, when it is descending into the pelvic cavity, the station of the head on the presenting part. Then next we assess the CPD also if the head is floating, and elasticity of perineal muscles. So, these are the few audition points we must note down while doing pelvic assessment. It is an abdominal method to assess the inlet contraction or contraction at the level of the pelvic brim. At this level it is assessed. In these cases, we know that head is the best pelvimeter, and after all at the end we need to decide whether this head enters the pelvic cavity or not. But somehow the head is floating in primigravida or sometimes, and in multigravida it is always floating. In these cases I want to assess whether this inlet is adequate for the fetal head or not by a method that is known as clinical method of assessing the cephalopelvic disproportion. Cephalopelvic means in relation to the head whether inlet is adequate or not. First we try to understand what is fixed head and what is floating head. Fixed head or floating head. Why the head gets fixed? At term in primi, there is good tone of the abdominal muscles. There is one thing which favors entry of the head into the pelvic cavity. There is formation of lower uterine segment. The part from lower part of the uterus, that is 3 inches above the isthmus, gets distended and stretched. With that the head occupies that place. And one hormone that is known as relaxin hormone is also secreted in primigravida, which favors relaxation of the joints of the pelvis and favors entry of the head into the pelvic cavity. So, that is how the head enters into the pelvic cavity. So, first decide whether the head is floating, fixed or engaged. Engagement also should be decided first abdominally, per abdominal examination. It is decided by the third Leopold maneuver or second pelvic grip. In these cases, outstretched hand is kept over the pubic symphysis like this, 4 fingers on one side and thumb on one side, and we palpate for the head. If the head moves, it is floating. If head doesn't move, then it is fixed. But if head is not felt at all, it is engaged. No? So, these 3 terms are used very frequently in obstetrics, and you must remember what is floating head, what is fixed head and what is engaged head. So, on this third Leopold maneuver or second pelvic grip, if the head moves, it is floating. If occiput enters and it gets fixed, the head is fixed, and head is not palpable, and in PV examination it is at the level of ischial spine, it is engaged head. So, this is a floating head, head is not palpable, head is moving. So, this is floating head and the head has entered the pelvic cavity. This is fixed head, only occiput has entered, here only occipital bone has entered, sinciput is still above. In engaged head, biparietal diameter has entered the pelvic brim, occiput has entered the pelvic brim, the head is not palpable per abdomen, is engaged head. So, this one is free floating head, this one is fixed head and this one is engaged head. Okay. So, that is how we decide, that is how the level of the head is with the different definitions. The descent of the head occurs at term also and with labor also. Okay. How do you measure the descent of the head? The name of the method is Crichton method. In these cases, it is examined abdominally and how much part among the 5 parts has crossed the pelvic brim we assess clinically. The descent occurs with labor after 7 centimeter dilatation of cervix. Major descent occurs from the ischial spine down to the pelvis and outlet. So, the major descent occurs with labor pain, but up to the ischial spines the descent occurs in primi gravida 15 days before expected date of delivery. On partogram, it is one of the clinical method to record the progress of the labor. On partogram, the descent is plotted by marking O or 0 station from 5 to 0, like that it is commented. Now, you have a look over this diagram and decide. Now, here 5/5 is palpable above the pelvic brim. So, I lay down on abdomen examination, the head is floating, 5/5 means whole of the head is palpable on abdominal examination here. All 5 parts of the head are felt. Next, 4/5 palpable once the occiput enters the pelvic brim, 3/5 palpable, little more entry, that is fixed head, but it is not at 0 station, it is fixed head, it is not above the pelvic brim, it has entered up to the level of greatest pelvic dimension. Next, I can make out occiput is the lower pole. So, first pole which will enter the pelvic cavity is occiput, then biparietal diameter, then sinciput. So, here in these cases, when the head is well flexed, you try to understand first which pole of the head will enter, occiput, then biparietal diameter, then sinciput. So, this is the level of occiput, this is the level of BPD, and this is the level of sinciput. This is sinciput and this is occiput. So, this pole will enter first in the pelvic brim. So, this is how the floating head will be, and next is 4/5 palpable, 3/5 palpable means head is fixed. Normally, the head is engaged or fixed also in primi gravida, but somehow on clinical examination the head is free floating like this. On second pelvic rib examination, the head is free floating like this. Then I try to identify what is the reason for this floating head. There are usually 10 causes for floating head in primi gravida at term. They are very easy to remember. If there is something like placenta or pelvic tumor or distended bladder, it is occupying the pelvic cavity, the head will not have a space to enter into the pelvic cavity, quite logical. Or when pelvis is contracted, that inlet contraction is there, that time also the head will be floating. Or whenever there is poor tone of the abdominal muscle, that cases also the head will be floating. Next, when the diameter of engagement is more, like extension of the head, deflection of the head in occipito-posterior position, the head will be floating. But remember, in the sequence, among these all 10 causes, this first cause is occipito-posterior position. This is a very important point to remember. It is due to deflection of the head. This is face presentation, this is brow presentation, and when the head flex, it is not well flexed, it is deflexed, means the diameter of engagement is less. This is well flexed head, this is deflexed, this is completely extended head, face presentation, and this is brow presentation. So, I will repeat, this is well flexed head, vertex presentation, this is deflexed head, occipitofrontal diameter, this is well extended head, in between the two incomplete extension is brow. So, let us learn what is this occipito-posterior position. Due to deflection, the head is floating. This is the commonest cause of floating head. This point you remember for MCQ point of view. Okay. Short gynecoid pelvis, naturally the head will not enter into the pelvis cavity, it is a small pelvis and it will be floating. Contracted pelvis, due to grand multipara, that is flat pelvis. Inlet contraction is there because of the osteomalacia. There will be flattening of the pelvis, that is known as flat pelvis. Next, face and brow presentation we have learned here. Face presentation, the diameter of engagement is more, brow, the largest diameter of engagement is there, that is verticomental 13.25 centimeter. Here face presentation, the diameter is more, but it is irregular face, that is why the head will be floating in cases of face presentation, in brow presentation. We have discussed placenta previa, if it is occupying the lower segment, placenta normally is in the upper uterine segment. If it is at the level of the lower segment, that is placenta previa. If it is occupying the pelvic cavity, the lower uterine segment is below the pelvic brim. So, there if the placenta is down, head will not enter. So, in placenta previa hydramnios also, there is a lot of liquor which prevents the entry of the head into the pelvic cavity. Hydrocephalus, the size of the fetal is too big to enter. Loops of cord around the neck which will prevent the entry of the head into the pelvic cavity. Pelvic tumor is as a space occupying lesion. Okay. So, these are the 10 causes for floating head in primigravida term. Usually for practical examination these causes are asked. Now, this engagement, what is engagement of the head? 3 points you must remember and you must tell in the practical examination. What are they? Engagement is head has biparatal diameter has already crossed the pelvic brim. BPD has already crossed. That is first point to remember. On PV examination, what level it will be? Naturally at the level of ischial spine, and abdominally it will not be felt abdominally. So, 3 points are BPD has crossed the pelvic brim, on PV examination it is at the level of ischial spine or 0 station, abdominally it is not palpable. So, that is engaged head. This definition of engagement is very, very important because it determines the difference between the fixed head and engaged head. Engaged head means abdominally it is not palpable. How do you decide engagement of the head? This is overall picture showing what is the station of the head. So, this is the pelvic inlet or brim, and this is the least pelvic dimension, and this is the pelvic outlet. In these cases, the head is at the level of the pelvic inlet, and in these cases the head is at the level of ischial spine. So, this is engaged head, this is engaged head, this head is fixed head. So, this is how engagement, when biparatal diameter has crossed the pelvic brim, it is engaged head. So, this diagram helps to understand what is engagement of the head. Crichton method is an abdominal method to assess the engagement of the head. Here in these cases what is done is, we are described floating head 5/5 palpable, fixed head means when I write down per abdominally it is 4/5 palpable or 3/5 palpable, it is fixed head. Only 2/5 palpable or little or no portion is palpable, means 2/5, 1/5 or 0/5 last is engaged head. Okay. After beyond that, the descent of the head occurs with the onset of labor pains. This is at term itself in primigravida. In multigravida, from here to here, from floating head, fixed head and engaged head, it occurs with the onset of labor pains. That is the difference in primi and multigravida. So, what is the station of the head on PV examination? There are 10 stations we examine and decide on PV examination what is the station of the head. So, like this, in these cases there are 5 points above the level of the ischial spine, and there are 5 plus 1 centimeter each, 5 points below the ischial spine. So, there are total 10 measurements. Okay. So, these are the different stations of the head. When the head is at 0 station, it is at the level of ischial spine. 1 centimeter below 0 station plus 1, very simple. 2 centimeter below is plus 2. You must understand these two levels, because the level of forceps application decides whether I have to apply forceps or not. So, the plus 1 means 1 centimeter below ischial spine, plus 2 means 2 centimeter below. So, below plus 2 we apply low forceps delivery, is done before that. So, that is how you remember the different stations of the head. There are total 10 stations. So, PV examination helps to identify the station of the head. Broadly, this diagram will help you to understand what is the, these two levels are inlet, mid cavity plus, -1, 0, plus 1, outlet plus 2, plus 3, plus 4 and 5 is on pelvic floor, This is about the bony pelvis. Plus 4 means it is on the levatorinae, plus 5 means at the introitus. This is the difference between plus 2 and plus 3 station. Okay. The descent of the head normally occurs in nullipara, means primigravida. during labor in nullipara it occurs more than 1 centimeter per hour descent, and in multigravida it is very fast, more than 2 centimeter per hour. So, in primi it is more than 1 centimeter, in multi it is more than 2 centimeter per hour. This is a partogram, I will show you why there is descent. Let us try to understand in brief. Because of amniotic fluid pressure, uterine contractions, bearing down effect. With the bearing down effect, the diaphragm contracts, abdominal muscles, rectus abdominis, they contract and push the head down, and extension or straightening of the fetal spine also helps for the descent of the head in labor. Okay. Major descent occurs after 8 centimeter dilatation of cervix, and in second stage after 10 centimeter. Second stage itself indicates delivery after 10 centimeter. So, it is hardly 2 hours in primi, 1 hour in multigravida. So, the partogram is a method of monitoring the labor. So, here the descent of the head is monitored on this line by marking at 0. This is -3, -2 station, -1 station, 0 station, like that. So, we mark the descent of the head and plot it on this line. It is in the form of hyperbolic curve. So, this is how the descent occurs at different levels. This is brim, pelvic brim, 2 centimeter above ischial spine, 1 centimeter above ischial spine, this is 0 station, +1, +2, +3, that is all. So, these 3 centimeters matters in obstetrics, you must understand. Here the bony outlet is up to here only, up to this level is 3. These are soft tissues behind. Okay. This is diagram to explain the major steps, movements of the head which occur in second stage of labor. It is very important to remember and understand this thing. Okay. The movement of the head is downward towards the sacral bone here initially to enter into the pelvic cavity. Internal rotation and twist at the neck occurs on the pelvic floor, on the levator ani, when head has already entered into the pelvic cavity here at this place. The internal rotation and the twist at the neck occurs. Then this movement of head is horizontal movement, and then there is extension. The head is borne out by the movement of extension in second stage of labor. So, first there is downward, forward movement, horizontal, forward, or this is extension of the head, forward, this is horizontal. So, downward, internal rotation occurs here, then the horizontal movement, and then head is borne by the movement of extension. So, here first what part in vertex presentation, first vertex will be seen, it is borne out, that is horizontal movement, and lastly the brow and then the face. So, this is the forward movement. How to identify in labor? So, this is the head here, it has entered the pelvic cavity, it has entered the pelvic floor, then it gets internal rotated here, means sagittal suture comes in the midline. So, this is internal rotation, this is a horizontal movement, and this is the extension of the head on the pelvic floor. So, first vertex, then brow, and then lastly the face comes out in labor. So, this is the movement of the head on pelvic floor. To understand it, I have given the arrows there. Okay. What is crowning of the head? Crowning of the head means this is the introitus here, and there is maximum stretching of the perineum. Initially what happens, with each contraction the head peeps out and it goes back by few centimeter, 1 centimeter say or half centimeter say. Again with the next uterine contraction it comes out, peeps out through the dilated introitus. But one stage comes when there is extensive extension of this stretching of this perineum, and biparietal diameter cross is at the perineum. It is at the level of perineum and it overstages it. One has to support it in labor. So, this is how the crowning occurs. The chin is in front of the coccyx and the subocciput fixes below the pubic symphysis. So, how to deliver the patient? I have to encourage extension of the head. So, with one hand I will give forward pressure and with one hand I will fix the occiput. So, this is how the delivery of the head is conducted. This method is known as Ritgen method. Ritgen method to deliver the head. What is this? It should be applied after crowning. So, you must know in the examination they ask you what is crowning of the head, and you must remember exactly the biparietal diameter is also on the perineum and it stretches the perineum. This is the method. With one hand we fix the occiput, with the other hand we encourage the extension of the head. Head is borne out by the moment of extension in these cases. What is the risk? Maternal risk with the descent of the head. If there is loop of cord around the neck, the head may not descend. With the uterine contractions, there is compression of the placenta also, and maternal tachycardia may be there, fetal bradycardia may be there. Maternal tachycardia and overstretched lower uterine segment is a sign of obstructed labor or impending rupture of uterus, or accidental hemorrhage can also occur. So, this is one of the complications in cases of prolonged labor, obstructed labor. So, remember I have to monitor the patient in labor so that there is no maternal tachycardia. Somehow tachycardia of 10 beats does occur in second stage of labor, but more than that is alert sign. Okay. Now, what it is? Cephalopelvic disproportion. How to assess it? Is by clinical method. There are two terms which are used, true CPD or inlet contraction, relative CPD due to problem in the head. The diameter of engagement is little big like occipito-posterior position. So, deflection of the head is a relative CPD. CPD occurs at the level of pelvic brim. So, in these cases you try to understand, here I am assessing the pelvis. Okay. Whether there is CPD or not at this level. Abdominal, the CPD is assessed at the by abdominal palpation. Okay. So, what we do exactly in these cases is, if there is cephalopelvic disproportion, then for non-recurrent cause caesarean section is there, and for recurrent cause always caesarean section is required. There are two methods to assess. One is Purandare abdominal method and the second is Manroka's modification of Muller's method. Okay. So, this is how the patient should lie down on the bed, and you hyperextend push the thighs over the abdomen, that is exaggerated adduction of the thighs is done, and with the pressure of the thighs the head may enter into the pelvic cavity, and by assessing the descent of the head abdominally, I try to understand whether there is CPD or not. So, this is how the patient will lie down, and with one hand, with the pressure of the thighs only, the head may enter into the pelvic cavity, inlet is okay. So, that is what is a Purandare method. The next method which is followed commonly is Manroka's modification of Muller's method. In these cases, abdominally, with one hand abdominally, in these cases here I will keep it like this, with one hand I push the head and with the other hand I assess the descent of the head in these cases. So, how to assess it? If the head crosses the pelvic brim, then there is no CPD. If on abdominal examination, on pervaginal examination, the head descends up to the ischial spine, no question. There is no CPD at all, the pelvis is adequate. Now, what is abnormal? Abnormality is when there is parietal bone is at the level of the pubic symphysis, is parallel with the line of the pubic bone, then it is borderline inlet contraction, borderline pelvis. In these cases, the treatment is trial of labor. When the parietal bone crosses the overhangs. When the parietal bone overhangs the pubic symphysis, it is major degree of pelvic contraction. I will repeat again and then show you the slides. Here, with one hand, the patient is lying down like this, with one hand, with the flexed legs of course, with one hand I push the head like this per abdominally, and one hand, right hand, I will do the PV examination. I am standing here like this, I will do PV examination and thumb of my right hand I will keep over the pubic symphysis. If it is not palpable on PV, it descends at 0, no CPD. If this thumb makes out the parietal bone in line with the pubic symphysis like this, then it is borderline inlet contraction. The treatment is trial of labor. When the parietal bone overhangs like this, it is a major degree of pelvic contraction. The treatment is elective cesarean section. Okay? This is how I assess the clinical assessment of the CPD is done. This is how I assess here. The head has already entered, the parietal bone has already crossed the pelvic cavity. So, or here it has crossed the pelvic cavity and here it is in line. So, this is borderline, it is parallel, and here it has already crossed the pubic symphysis. So, this one is borderline inlet contraction, this is normal inlet. Okay. Next one is parietal bone overhangs. This is pubic symphysis, parietal bone overhangs by 2 fingers like this. So, it is inadequate pelvis, the plan is elective cesarean section. There are other modalities also to determine the adequacy of the pelvis. MRI is the best among them, CT scan is the next in order, and lastly the X-ray. But radiation exposure due to X-ray is avoided in pregnancy, it should not be done. So, that is how we assess the pelvis clinically. Thank you so much for the patient hearing. Thank you so much.